Welcome everyone to Advancing Evidence-Based Decision-Making for COVID-19. My name is Macis. I'm the moderator today. I'm a professor of economics and management at the Carey Business School. I'm also affiliated with the Berman Institute of Bioethics and the Hopkins Business of Health Initiative. I realize that everyone is busy and preoccupied with the epidemic and also with everything else that is going on in the US right now, and I just want to thank you for joining us. This is a Johns Hopkins webinar series. Our goal is to provide an interdisciplinary forum to advance evidence-based decision-making for COVID-19 and for future pandemics. The series is organized and facilitated by many schools and departments at Hopkins, the COVID-19 Modeling and Policy Hub, the Infectious Disease Dynamics Group, the Hopkins Business of Health Initiative, the Alliance for a Healthier World, the Department of Economics, the Departments of Epidemiology and Health Policy and Management at the School of Public Health, the Berman Institute of Bioethics, and the Bloomberg American Health Initiative Evidence Work Group. Special thanks to Kate Gerbowski, Dan Polsky, Marcelo Ariel Fernandez for co-organizing the series. In today's webinar, we are going to be talking about targeted lockdown as a possible strategy to control the COVID-19 epidemic. We are very excited to have the 4 authors of a new study titled Optimal Targeted Lockdowns in a Multi-Group SIR Model. The authors are all economists, all professors at MIT, Daron Acemoglu, Victor Chernozhukov, Iván Werning, and Michael Whinston. The paper will be presented by Iván Werning. Thank you, Iván. And Daron and the other co-authors, Victor and Michael, will be available in the Q&A feature of Zoom to answer questions from the audience. The audience will remain muted during the talk, but of course, please, we invite everyone to engage and ask questions. Iván will have 35 minutes to present. After his presentation, we will hear from 2 discussants who are not economists in this interdisciplinary spirit of this series. Jessica Metcalf, who is a professor of ecology, evolutionary biology, and public affairs at Princeton University, and Ruth Faden. Ruth Faden is a professor of biomedical ethics at the Johns Hopkins Berman Institute of Bioethics, and she's also the founder of the Berman Institute. Professors Faden and Metcalf will speak for 5 minutes each. After that, we will have reactions from the authors and a moderated discussion. Thank you to the authors and the discussants. With that, Professor Werning and Iván, the floor is yours.
Thank you. It's a pleasure to be here and present this paper. I want to thank the organizers and the audience and especially the discussants. We look forward to comments on this paper. Let me get the screen sharing going. Okay, I'll assume you can see that unless someone hollers. So yeah, this paper, I want to first start off by saying that we put it out about a month ago, and we did a pretty major revision. So we actually made minor changes to the title that I think signal that there's some major changes in the paper. And let me just go right into it. The paper is concerned with policy analysis for COVID-19. And when we think about the policy analysis, thinking about models that help guide us in that analysis, there are tons of course, contributions from the epidemiology literature. Concepts like herd immunity, the effects of mitigation policies, their timing, testing, etc. Right? What we bring to the table, we're economists, I think might help combining these enormous insights with thoughts on the costs of lockdown, how to think about the most efficient policies taking into account both things, and what is often called optimal policy. All right. And when we think about COVID-19, we thought a very important principle to bring to the table is to think about, at least consider, more targeted policies. One reason for that is there are dramatically very heterogeneous effects of this disease on different risk groups. In particular, mortality is very different, and one particular risk group, covariate, is age. Very important differences in mortality. This is using Ferguson, which we're going to use for the most part, just to kind of take the conservative numbers. But the general picture that's important here is the slope with respect to age. And although there are some discussions about the levels, I think most people agree there's a very steep slope on age. So for us, addressing the policy question of COVID-19 without taking into account this enormous differences is missing a very important piece. So that was our starting point. And so in this paper, we're going to use a simple multi-group model that is common in the epidemiology literature. And perhaps what we have to contribute is to explore optimal policy in that environment, okay, using techniques of optimal control, and in particular, look at targeted versus non-targeted policies, okay? So in a nutshell, what we're going to do is apply this to a calibrated version of the model with 3 groups. We're going to do one extension with 4 groups, and we could do more. We're going to calibrate it to the best available evidence. And then we're going to study this optimal control policies using targeted policies, but also uniform non-targeted policies. And the main point of the paper is to compare these two, okay? See how big those benefits are. And my interpretation is, if it's important to explore how big those benefits are, then perhaps there are concerns or implementation issues. But if we don't know what the potential benefits are, we can't weigh the two against each other. So we're going to be calculating what these benefits are. Let me just say at the outset, it's obvious that with a targeted policy, you can do better. You can't do worse because you always have a targeted tool now, and you can decide basically not to use it or to target very little. So you can't do worse. So it's a quantitative conclusion that we're looking for. Just how much better is it? It's potentially possible that targeting is always a good idea, but when you use it, you get very small benefits. Okay, and if we didn't know what would come out of this study, and if that was what came out, we would be reporting that. Okay. Instead, what we find is very large gains from targeting policy. Okay, relative to a completely untargeted policy. All right. And the way we like to portray this, if you take one figure away from this paper, it's a conceptual picture. We're going to give you a numerical quantitative version of this later. But if we think of 2 objectives, one is decreasing mortality, okay? And the other is decreasing the output losses, all right? And obviously, we would love to be at the origin here, 0 for both, according to this pandemic, 0 output losses caused by the pandemic and 0 mortality. But that's not going to be feasible. And of course, some very bad policies might put us up here, okay? And there's a lot of work in figuring out we shouldn't be up here, we should move this way, okay? And if you use the best optimal uniform policy, we say, well, you end up with a menu of choices here, okay, that is depicted by this frontier. And this frontier, is the ugly trade-off that inevitably a society faces. And as economists, it's typical to go one step further and pick a point on this frontier. An important thing we're going to do today is not do that. We want to spell out the options. We realize there are enormous ethical issues in choosing a point on the frontier. And we like to separate the fact of sort of understanding well what the trade-offs are, and then thinking about how society arrives at a decision at what point to be on that trade-off. All right. So that's one important contribution that you might see is different from what most economists do. They just tell you what to do. No, we're not going to do that. We're going to be spelling out options. And when we do this, so we like to depict the options in terms of this frontier. Now, this is the frontier when you're using uniform policies, okay? Policies that do not target different groups differently. The whole point of the paper is to say, well, if you use a targeted policy, you get to move this frontier out, okay? And if you move the frontier out, you're better off because you'll get closer to this origin, right? Now, once again, it's not clear which point we're going to pick on the new frontier, but if we use targeted policies in the correct way, we can do better than we were doing with uniform policies. Let me try and say this again because it's very important. It's kind of a philosophical point that it took me time to get to. But basically, you know, we're not going to pick which point on this frontier to be at, but say society is picking this one. We just look out the window and that's what society is picking somehow through the political struggle or whoever is deciding. And our point then can be viewed as saying, well, then if you're using uniform policies and you are on the frontier of those uniform policies, we want to suggest you consider this other region here that's strictly better off, both in terms of economic losses and in terms of saving lives. Okay? And that's the pitch of the paper. Okay? We're not going to tell you what to do. All right, so that's the main point. And the main point is quantitatively, these distances are quite large. They obviously depend on where you look at them. If you were going for minimizing deaths, absolutely minimizing deaths, okay, which I think no society is currently doing because lockdown policies are not at their strictest, okay, then there would be no gains, okay? So it's a statement about sort of, you know, this distance, and we're going to point out to different points on this frontier and what those distances are, okay? Right, so let me come back to the point. This is a bit of a long introduction, but I think it's important to get the concepts out well. What we find is large gains from targeting. And I said theoretically that is obvious as a matter of, sorry, the direction it's going is obvious. The point is they're not small, okay? They're substantive, and that's not obvious. And to underscore that point, we actually show that once you target the very elderly against the rest, and for us, the very elderly, pardon some people in the audience, is everyone above 65. Once you target that age group and you treat everyone else the same, there's not a large gain in treating the middle age differently than the younger group, okay? That underscores that our conclusion was not obvious because it's not always true that targeting further has substantial gains. We find that, yes, if you start from scratch with no targeting, but once you have this amount of targeting, there's not very significant further gains, okay? They're small, right? Let me underscore something else that is often, if people read our paper in diagonal or read other people's accounts of our paper, which we do not recommend, we recommend you read us or listen to us. We are not saying that it's optimal to let the young go free and have zero lockdown for the younger groups. That's not our conclusion, as I'll try and show later, all right? We're just saying it's better to have a differential lockdown. That does not mean, you'll see in our graphs, it doesn't come out that, you know, that you want to let the young all free, all right? Which often is misread from our paper, I think. You know, these days you write a paper, it gets caught in the political crossfire. It's interpreted by both sides in their own way. And so I'm happy to here to clarify that. Another point that comes out of our analysis is testing is very important. We wrote this paper when it wasn't obvious, and I'm not sure how obvious it is today yet, that the US would be able to ramp up testing quickly enough, right? And for many other countries, it's probably even less obvious that this is going to be possible. But we also, even if testing is is eventually available, there is a period of lockdown that we have to study, first of all. And secondly, we do show that testing in our model is incredibly helpful. Okay, this is in line with so many studies, but I just want to say it's consistent in our framework. We're actually going to show you some numbers about testing. I always bring this up. Important caveats to our analysis, I think anyone's analysis, but sometimes it's important to emphasize we're not epidemiologists. We've asked questions to epidemiologists. We're happy to talk to them. We've learned a lot from them. Like I said, I think we bring something to the table, combining their insights with some economic tools. Model specification and parameters are very debatable, very uncertain today, okay? Especially, you know, we're still learning about this disease. And our results, like many others, are going to point to the fact that the optimum or the efficient allocations are very sensitive. The efficient policies are very sensitive to these parameters. So to say something very conclusive, you know, we ask science to be very conclusive. We can't. We don't yet know everything about this disease. So we're going to share with that uncertainty with other people's analysis. So we don't want to overclaim a certainty of what has to be done. I would even underscore that actual policy prescriptions, obviously this is a model, I think they're very helpful for thinking about the world, But then whenever you go from the model to the world, you have to add some things. And there's an art in policy making that it implements and tailors to the situation on the ground. And we, when we speak about what's an efficient policy, I'm going to not repeat it every time. It's within the context of our model. And then we can always have a conversation of whether we're missing something important. We've done the best job we can, but that's an important caveat. We hope our analysis, though, by focusing on a prediction that I think is more robust, which is what the gains are, we'll find that prediction is more robust. Many other predictions depend on parameters a lot more than the prediction that we're going to focus on today. Okay, that there seem to be robust gains from targeting. And finally, we welcome comments and suggestions, which is one reason we put this paper out early. We got a lot of comments. We really worked hard on the revision, and we still welcoming comments and suggestions and critiques. So let me outline the talk. I'm going to present the model. I understand I'm not going to present the details, all the mathematical details, but I want to give you a sense of the model. Then discuss a few concepts within the model, but then turn to the calibration and our numerical results, the quantitative results given that calibration. And then talk about some robustness exercises that we're undertaking. And every week we are doing a new robustness exercise. Might spill into a follow-up paper, really. Okay, so let me go into this multi-group SIR model that we have here. Just to jump into the model, and then I'll kind of go trace my steps again, but there's a key equation in all these models, which is what determines new infections. And there's a level of infectiousness of the disease, this coefficient beta, which is a constant. And then there's going to be more infections if there are more people that are susceptible to be infected that are not yet immune or not yet infected. That's the susceptible group. And also more people that are infected, because then there'll be more contacts between the two groups. So the basic equation, the basic setup, you can think of other equations, but the basic equation is that it's just the product of these two values, the product of susceptibles to infected. All right, times a coefficient that controls how infectious this disease is, how easy it transmits, and also things like behavior. If everyone starts wearing masks, maybe beta falls, all right? Okay, so what we're doing here is a version of this model that's also known in the literature as multi-group or stratified by age, et cetera, by risk group, where we don't just have one group. This is the basic one group case. We have many groups. Here I'm illustrating two groups. Okay, so we would have group 1 and group 2. Maybe this is the young, this is the old. And as in the one group case, you go from being susceptible to being infected, and then hopefully to recovering, or in the bad outcome to dying. And the reason you go from S to I, as explained by this equation, is because there are interactions here that lead to infection. Okay, all I want to say is in the multi-group case where there's two groups or more, we have the same row here for another group. And the main thing I want to stress is, and the assumption is not these two groups live in completely apart in separate islands, but they're also interacting between each other, and that's leading to infections, okay, right? So there's sort of a network contact matrix lurking in the background here, all right? And that's important and will be part of our analysis, all right? When people are infected, we're going to have a fraction of those needing intensive care, or and another fraction having a milder version of the disease, right? And that's going to be important for thinking about another goal is going to be to take into account that mortality might depend on the amount of infected that need care at any point in time, right? If the hospital is overwhelmed, the idea is mortality will be higher. And we're going to deal with that in two different ways that I'll show you later. Okay, but the basic model is there's some fixed amount of people in each group, and the people are going to be either susceptible, infected, recovered, or dead, right? And the basic equation, generalizing the one I had at the top, is that the new infections now in group J is again given by some coefficient times the amount of people susceptible in group J but now multiplied by the total amount of infected that they're interacting with. And those interactions are weighted by how often people contact people in different groups. So these are these coefficients rho JK, all right? So if rho JK is very large, that means you interact a lot with one group. That's obviously an important element here, which controls these interactions I mentioned earlier. Okay, I'll come back to this equation in a bit when I introduce the mitigation lockdown policies, okay, to see how those change. Let me back up now and describe the model in a little more detail to bring in the economic component, all right? So I mentioned this already. We're gonna have J groups. We're gonna, in our application, have capital J, B, 3, sometimes 4. And anyone that's new, that becomes infected is going to develop either a mild version of the disease with some fraction 1 minus iota, and a fraction iota is going to be a severe version of the disease, which we call ICU as a stand-in for that. At the same time, every case, every infected resolves either as a recovered or is dead at each period with probability gamma J, all right? So this is the rate at which cases are resolved. And the mild cases, they all recover. The ICU cases, they're going to be split between those that recover, which is this, and those that die. And this is the additional thing I wanted to say, that death rate is going to be depending on how much overuse these hospitals have, okay? So there's going to be some baseline mortality if there's hospital use is way below capacity. And if instead hospital use is much higher than capacity, then those death rates are going to be allowed to go up. And we're capturing that by saying that the death rate is a function of total hospital use, which is capital H, and total hospital use is just the sum of the hospital use by each group, which is the amount of infected times iota, all right? Okay, so this is at a general level. We're going to specify specific forms for these functions later on. Okay, moving on, we want to imagine that not everyone who's infected is causing infections because they might be isolated. So, and this is before thinking about lockdowns. Imagine, you know, you're sick, you show symptoms, so you isolate yourself, or you visit a doctor, and you become hospitalized, and you're isolated from the rest of society. So we're gonna imagine that there's a technology which is testing and isolating, which we're just going to summarize by, okay, a fraction tau of those patients, those infected agents that are mild, are going to get isolated. They're going to be tested and isolated. So you should think of this number as pretty low in the US today, okay? And this is the number we really want to ramp up in the US. Then there's the patients that will need attention, and those will also be isolated with another probability, which might be higher because they show symptoms, they end up in the hospital. So obviously this number might not be 1 though, because there's a time interval over which you didn't show you symptoms yet. So that's how we're thinking of these parameters, okay? Basically below 1, in this case, very below 1, because we're still working on ramping up those kind of testing capacity. All right, the bottom line of all this is that, that if there was no testing, the amount of people that would be not isolated, the fraction would be 1. Instead, thanks to these technologies for testing and isolating, the fraction that is not isolated is eta j. Okay, so this eta is going to be a number between 0 and 1. If it's close to 1, it means we're not isolating many people. If it's close to 0, we're isolating a lot of the infected. Okay, that's going to be a parameter that's going to affect the basic equation I showed you earlier. Okay, the other another important assumption. We're going to assume that the recovered agents are immune, all right? And this is obviously an assumption. I think it's the leading hypothesis, but obviously it's not been proven to any of the sort of medical gold standards that we have. But, and I know the WHO has warned that we have no proof of this. We're going to take this as our leading hypothesis because I think, as you'll see, as I'll describe in a minute, we're talking about the epidemic for a year and a half, imagining a vaccine arrives. And if there's a lot of doubts, there's much more doubts about whether one can become immune for a much longer period than a year and a half. Okay, but nevertheless, this is an assumption we make, I think, in line with most people's preferred assumption. And then we will imagine that those people that are detected to have had the disease and are now immune can go back to work and maybe avoid the lockdown. We're going to have a parameter to control whether that's the case or not. Okay, so kappa is that parameter. So if kappa is 1, it means if you've been infected and are now immune, you can prove it and you can go back to work even if there's a lockdown. Okay, so tomorrow I actually have to go to MIT to get tested, and I don't know yet if this is the way they're going to proceed. But as part of allowing me going back to work, they're going to start testing, going back to the office. Okay, we can play with this parameter, and maybe we think it's unethical or there are issues with providing immune cards, so we can set this to 0 as well, and we'll do that. Okay, we come to the lockdown, and this is going to be at every point in time. We're going to lock down a fraction Lj of group J, okay? And the idea is these people are removed from not allowed to go to work, not interacting in other ways in societies, asked to stay home, and that's this lockdown value. So if it's 1, everyone's locked down, okay? Now we're going to assume realistically that we can't go all the way to 1 with everybody because they're essential work, etc. So we have a parameter L bar, which we think of as roughly 70%, for instance, that is a maximum you can lock down, okay? Because things like food, medical, transport, etc. have to keep going, right? Also, very important, and sometimes people don't read our paper and think we don't assume this. We're not going to assume that lockdowns are perfect. So if you lock down, even if you did lock me down 100%, so you set L to 1, we are going to assume you still interact with the rest of the world. Maybe because you cheat on the lockdown, or maybe because you needed some essential services like medical services, etc. And so that lockdown isn't perfect, okay? Or you have people in your household. So it reduces the contacts, but it doesn't take them to 0, okay? So we're not assuming perfect lockdown, which would be crazy. Okay. That means that that the fraction that's being removed, the fraction that's remaining and interacting with society is 1 minus theta times L. So both theta and L being small contributes to having a lot of people that are infected interacting and getting people sick. All right. Finally, I said this, I anticipated this. We're going to look at policies over a year and a half, basically. So we're going to have a capital T that, we're going to assume the vaccine arrives. And to simplify matters, we're going to assume a cure also arrives at the same date, although we could probably treat the case where it's just a vaccine, all right? So in other words, this amounts to saying we only care about infections that occur in the next year and a half, all right? After that, we're going to be home free, all right? And we've done extensions where we don't know what cap T is. Maybe it's a year and a half, maybe it's a year, and it's a stochastic variable. So that's an extension. We're going to be looking at the case where we just set it as a number, though. Okay. Okay, so coming back to this is the same slide I showed you earlier. I'm just showing how I modified it with these mitigation policies. We're going to have this factor here, which is the amount of people that are pulled out of the susceptible pool and sent home. And then we're going to have this factor here, which is the amount of people that, because we're removing some people from the infected pool and sent home. We're also removing some people because of the test and isolation, which is the role of eta here. So those are the 3 changes relative to what I showed you earlier. Okay, but basically it's the same equation. Okay, we come to the economics part. We're going to be looking at efficient policies like that frontier I showed you. And to think about that, we have to summarize any given policy and its effects on the epidemic in terms of 2 numbers. The 2 numbers we're going to look at are total lives lost. Okay, so the amount of deaths accumulated as the point when the vaccine arrives, after which there'll be no it's assumed there'll be no further deaths, and the economic losses that are incurred during that epidemic to mitigate. Those economic losses will be shut down, people not working because they're shut down, but also we're going to include the lost earnings of people who die. So even when you know, it's not the case that opening the economy fully up is best for the economy. As we showed in this frontier here, it even slopes up. Okay, we'll never want to be on that side of the frontier, but it's capturing the fact that there are economic losses even from these deaths. Okay. Okay, so I'm going to skip the details of the mathematics of that, but basically the idea is we're measuring total output and we're penalizing for the output loss due to lockdowns, and we're penalizing for the output loss due to deaths. Okay, that's the economic losses. And then we're not just going to consider economic losses. That would be insane. We're also considering that there's a special value to reducing mortality. And again, the whole point of the paper is to draw and think about this frontier more seriously. Okay. Another approach which we do not take, and I don't know how often it's taken outside of economics, but is to put a value on life. Okay, value of a statistical life. And in that case, one would consider the sum of the economic losses and the lives lost times a parameter which captures how to convert lives into dollars. Okay. Essentially, that's going one step further than we want to go today. That's saying, I'm not just going to show you the frontier, I'm going to use a value for this. And that's going to give me which point on this frontier I want to be at, or which point on this new frontier I want to be at. Okay. And we think that's a controversial thing to do, because the concept is controversial, but also even if you accept the concept, it's incredibly uncertain what this value of life is, and people argue about it all the time. So we just prefer not to go there, right? So we think that's a valuable part of our approach as well, is to sidestep that tricky issue.
I'm just chiming in 5 more minutes. Thanks.
Oh, I have that I've only spoken for 26 minutes and I thought I had 35. Okay, maybe you counted your introduction. I'll speed up.
That's fair. That's fair.
Okay, if you say that I have 5, I'll do what you tell me. But
go ahead.
I had a timer. And okay, the gains from targeting. I just want to make a conceptual point, then just show you these figures. The figures are easy to show you, so let me spend 1 more minute on a conceptual point, because this is important. Why are there gains from better tailoring, from better targeting? One is a trivial point, or not subtle. I don't know if it's not, it's just basically we should tailor to a situation. This is not specific to an epidemiology model. If people, different vehicles will have different speed limits. It's a basic point, okay? And so we might want to raise the lockdown for the old and lower it for the young. That's a very natural, intuitive point. A more subtle point that is a little more specific to the epidemiology models is that the old might even benefit from having a laxer policy for the young, okay? This is a more subtle point, and it's captured here on this figure. We're showing the amount. This is a case where there's only two groups. Imagine we just had the young and the old, and then there's we start with very low rate of infections, so we're very close to this upper point, and we're going to travel if we had no mitigation policies along this dotted line, and we would end up in this region of herd immunity, and we'd stop at some point, okay? Now, mitigation policies are going to either slow this down and maybe stop before we reach that point and get the vaccine, all right? But what we're saying, what targeted policies do is actually do that as well, but shift you to these kind of arrows, okay? And for instance, suppose you're still allowing the situation to go to herd immunity, you're still going to reach a very different form of herd immunity, one that has more susceptible old, less infected for old people, and thus lower mortality. And you still might do this and end up trying not to go to herd immunity and reach a point where you get the vaccine before that, all right? So both things are possible, but there are further gains, and those gains might accrue even if we only lower the lockdown for the young. I'm not saying that's the only thing we're going to do, but there are these two effects, and it's important to understand that. Okay, maybe I have bad time management today, so I'm going to say that the parameters we're going to calibrate this to, I said, is the Ferguson mortality data. We're going to set an R naught that's 2.4. Okay. We've played with a lot of the other numbers. So let me just say here, we're going to assume the disease lasts for 18 days. We've done a lot small, you know, if you add an E to this model, so you have an SEIR, you can separate how long the total disease lasts for with and how long the period of infection is. And we've done that as well, and we get similar results. And then we're going to like take a conservative case where there are a lot of interactions between all the groups. Mm-hmm. This is important. We're going to later then calibrate this, but we first want to take a, you know, you might think if I loosen the lockdown on the young, one concern is that the old are still interacting with the young. So we're going to kind of look at a worst case scenario where there's still, where this interaction is very even. When we calibrate it, it's actually going to push the mass more towards the diagonals, but we're going to start with this uniform case. These numbers are just economic numbers, basic economic numbers. As far as mortality from hospital use, we're just going to assume that it increases linearly, and we're going to calibrate it so that when infections are 10%, which is a large number, the mortality is 10% higher. Okay, so a factor of 1.1 is what I mean. Mm-hmm. But we're going to also impose, which is much more common in the epi literature, a hard constraint on the total level of infections. Finally, we're going to start with a case where testing is in isolation is very low, so eta is 0.9. We only isolate 10% of those infected. And we're going to assume that the lockdown is 75% effective, so there's still 25% interaction. And that the maximum lockdown for the middle and young groups are 70%. Okay, and we're going to allow full lockdown of the old, motivated by the fact that they're less attached to the labor market. In our baseline, we're going to have this immunity card, but we're going to expose it. We're going to look at the opposite case later. Okay, in the interest of time, I'm going to skip this basic economic parameters that I was setting up. This is the takeaway figure that shows you the numerical version of the figure I showed you in the introduction. So here is the frontier if we only use uniform lockdown policies. And the green line is the frontier if instead you use targeted lockdown policies, okay? And here I have the fatality rate within the adult population, not the total population. And these are the present discounted value losses, okay? So 1 would be 1 GDP. So let's say 0.2 is 20% of GDP annual, right? So you see that there are significant gains either in both reductions in mortality or reductions in economic costs along these two curves, okay? So to illustrate that, I'm going to talk about two policies. One that which looks for a mortality of 0.2% of the adult population, okay? So it's way up on the left here. And another that is looking to keep the economy losses to 10%. So it's over here. So I'm going to sort of compare this point to this point and show you what those policies look like. Okay. So first, I'm going to show you on the frontier when we're using a uniform policy. So it's this point over here. Okay. So this point over here, look at the lockdown. It's around 50% of the economy is locked down. All right. And it lasts for a very, very long time. Okay. And in fact, we're not achieving herd immunity. We are waiting for the vaccine in this simulation. All right. If you look at the amount of people total infected, it reaches around, I think, 20%. I don't have that number in front of me, but and this other simulation here is instead another point on the frontier down here where we care more about the economy. We let mortality be higher, and of course the lockdown is lower, still not trivial, but there's a lot more infections. And here we're summarizing there's about 1% mortality in the adult population. Okay, so this is the more economy focused, we call it. There's only 10% loss in GDP. This is the more safety focused, where there's only 0.2% mortality rate. And the economic loss is much larger, 37%. Okay. So let me skip this in the interest of time. Now what I'm going to show you is the punchline is, well, now let's look at points on this frontier, okay? So I'm going to reduce, if I'm looking at the safety first case, I'm going to go to this point where I still keep mortality at 0.2%. But now I lock down the old fully, okay? And I still am locking down the young and the middle-aged, only slightly less than before, okay? But the gains in terms of the economy are significant, okay? Around 12%, right, of GDP. And we have the same mortality with lower economic losses. We could also take the economic, instead of taking economic gains, we could reduce mortality, okay? This was arbitrary here just to illustrate. Finally, the bottom figure here is showing you the economy focus, so where we were keeping losses at 10% and we traveled to the new frontier. And again, we see that there is an important targeting. And in this case, there's a big reduction in mortality. So mortality goes from, remember, around 1% to around 0.5% for the adult segment of the population. Okay, running out of time, so I'm gonna scramble and just say, in the paper, we also go to a fully targeted, I'm skipping that, and we show that there are very little gains from further targeting the young versus the middle group, right? So if you looked at that frontier, there were actually two curves that were almost on top of each other, okay? And I'm gonna pick just one random thing to show you maybe to end this because, okay, let me show you two things. One is testing. In our model, when we introduce higher testing, these frontiers travel towards the origin naturally. And quantitatively, very good testing and tracing just basically solve the problem, okay? Although the best combination is a combination of testing and tracing and group distancing, which lowers the interaction across groups. So we say that in terms of our figure as, you know, we can further shift the figure out, the frontier out if we improve testing, obviously. Let me end with one. I'm going to skip. We have a lot of robustness checks. Let me show you just one because it's something kind of hot off the press that we did. And if instead of assuming a uniform interaction, we calibrate that to the BBC Pandemic Project, which is newer than the polymode evidence. And this is our contact rate matrix. Okay, when we do that, we still get similar results in terms of there being a very important gain here from moving from uniform to targeted policies. Okay, so we would summarize, you know, there's differences that I don't have time to go into in what the policies look like, but not that different in terms of lockdown, qualitatively speaking, and not that different in terms of quantitatively what the gains are, okay? So let me conclude, and sorry if I went over time. Let me leave it here.
Thank you very much, Iván. People can clap in the privacy of their homes or using the Zoom emoji. Please also continue to contribute with questions in the chat. We will now proceed with our discussants. Professor Jessica Metcalf from Princeton University will now offer some remarks. Professor Metcalf.
Great. So first of all, I want to say that I've been told that the social norm among economists is rather more forceful than the social norm in our communities. So I've gone that way. I hope I haven't overcorrected, and I hope you won't take offense, Iván. So we're starting from the same place. Most of the world is still susceptible to a highly transmissible and lethal pathogen, but we can't maintain the current lockdown. And the model thinks about the impacts of locking down specific age groups at different levels. George Box said, all models are wrong, some models are useful. I'm not sure this model is useful. There are two ways that models can be useful. One is they give us insight into some counterintuitive outcome, or they resolve some paradox. And infectious disease biology is rich in these, from herd immunity itself to the effects of seasonality on driving phenomena like chaos. This model doesn't do that. The second way in which models can be useful in this setting is to guide policy. I don't think the model quite does that either. And this is because first, empirically, we have evidence that we're terrible at protecting our older populations. Nursing homes from Sweden to California have been devastated. And if you imagine that that's happened even before you allow an outbreak to rage outside, it's likely to lead to poor outcomes. And of course, it's clear that we have to get better at that. But we didn't need this model to tell us that we need to get better at that. There's also the complexity that in many settings you get multi-generational households, and the only way in which adults can go to work is because grandparents are taking care of children. That complicates this particular policy. And finally, we know it's not just about old people. We know that they're diabetics. There's a whole suite of vulnerabilities to this pathogen, which would be hard to identify and to pin down as you let the epidemic rage through a particular group. So that's the empirical side. On the other side, the model makes very precise predictions, but I think it's quite tricky to be confident in those predictions for a number of reasons. First of all, there are some puzzling parameter choices. So for example, gamma of 1/18, I was delighted to hear that you've revisited that, because that is surprising. The patterns of, as a demographer, I'm sort of contractually bound to point out that births happen, death happens, and so does aging. And this matters in the context of this scenario, because even over the course of a year and a half, individuals are likely to go skidding up that exponential increase in risk at the late age classes. And the births matter because if you're moving out beyond 1 year or 1 year and a half, it is arrival of new susceptibles into the population that will shape the burden that we're facing. The question, I was also delighted to see that you'd probed the polymod, beyond polymod, to look at the BBC pandemic estimates. But this is also a knotty issue. We've spent decades as epidemiologists trying to grapple with what the relevant magnitude of contact is. And outcomes, you can use this simple next generation method to show that outcomes can be quite sensitive to the nuance of this. Yet we have it poorly characterized. It's likely that this is partly because these networks rewire all the time in human populations, and because we also don't observe transmission, so it's very hard to pin it down. So all those phenomena aside, I think the one that raised my eyebrows the most was this idea that the vaccine would arrive in 1.5 years. We might never get a vaccine, and I think we should be thinking about our policies in that context. If we do get a vaccine, it could be much, much further down the line. And optimal control theories, it strikes me, when I've done them before, have been quite sensitive to what the endpoint is. I was delighted to see that you'd done sensitivity to a Poisson arrival time, but I wondered how much they had changed the predictions. I think that the question of, so, you know, it's possible that you got all of that exactly right, and the predictions are completely sensible in terms of what fraction of the population should be locked down over what time frame. But I think the third reason this is potentially not terribly useful is because that's not actually how public policy gets implemented. We can't shift along a gradient of we're going to move from 70% to 60% over 7 days and then shift that. The levers are much coarser. I work a lot on measles vaccination. We know precisely, or we can identify to a pretty close degree what children are susceptible. So we could say we want to target this age class, but no, the public health policy levers that you can play with are we drive a campaign that vaccinates kids up to 5 years, up to 10 years, and up to 15 years. This is not so much an optimal control problem as a satisficing problem, because public health, precision public health is still an elusive goal. However, you know, I do like this model very much, and I am excited by the combination of epidemiological and economic modeling. I think it's terribly important, and I very much like the effort that Kate and colleagues have put together here. I think actually the biggest gap at the moment is not so much models as data. I think we're doing this huge experiment at the moment where we unlock, or we release communities across the world. But I worry that we're squandering opportunities to learn about what this means for both the infectious disease side, but also the economic and psychological side. And I think all these communities should be working closer on that. I also think that models are certainly useful and certainly part of this. One thing I really liked about your model was the kappa parameter. So this is the parameter that says what fraction of the population can return to work because they have a sort of immune passport of some kind. So there's a whole suite of issues around that, as you mentioned. And I think there's probably a rich array of non-linearities to do with economic issues that I don't really understand that could result to this being quite a funky set of outcomes. But what I learned from your paper was that it looks like the impact isn't actually very big. So that was surprising to me, and perhaps has something to do with the timescale as well. But that was something that was counterintuitive and surprising and really interesting. To conclude, I think that this effort is absolutely welcome. I'm not sure the specific iteration is useful yet. It is very hard to write down useful models. I'm sure I fail that bar. I know I fail to meet that bar all the time, but I'm holding you to that high bar because you are eminent and influential economists, and you should be held to a high bar. And also because there's a pandemic on and an economic crisis on. And if you live in the United States, the consequences of systemic racism are compounding the outcomes. And so I think we should strive to make our models useful. That's what I have to say.
Thank you, Professor Metcalf. I'm sure that the audience and I am, very much looking forward to the author's responses. But first, Professor Faden from the Berman Institute of Bioethics will offer her remarks. Professor Faden.
Thank you, and I want to thank the authors of the paper and the organizers of the seminar for this opportunity. I come from a very different space than either the paper authors or Jessica, but I think there's going to be some resonance between what I have to say and what Jessica has said, although it may sound very differently. I've got 5 points I want to make in 5 minutes. Actually, 3 are observations and 2 are more like questions or queries. My first observation is that I agree with you that it is prudent not to go the strategy of putting a price on life. We can discuss this later, but I very much like the fact that you presented a frontier and didn't pick a point. I think that's very helpful for a lot of policy reasons. I also like the fact that you use lives saved and not years of life. Very contested territory worth much discussion. So that's my first point. My second point is that I see the major near-term value of the paper to the public policy debate to be twofold. First, I think it is important, your finding that adding the middle-aged to the elderly did not gain much value. We can talk about that more hopefully in discussion or afterwards. More importantly, I thought that what you identified in terms of the finding of the model with regard to the big impact in keeping the over 65s in a deeper lockdown is important for what I call the soft public policy, which is going on right now in many states. As states reopen, there's often a caution from stage to stage at the bottom of the stage that says, if you are at higher risk, which includes if you're over 65, you should try to stay home as much as possible. Right? That's part of pretty much every state's guidance. And it's the voluntary soft expression of what you're saying, but I think that findings like this provide a certain additional oomph to public health policymakers for a message they already want to deliver, right? So that's my second point. My third point is the one that I think most people would turn to those of us in ethics to comment on, which is whether this is unjust discrimination against older Americans, or is it ageism to have such an explicit policy, especially when you talk about using the language of lockdown. So let me just say 3 quick things about that. First, Iván, you apologized to the people in the audience when you called them the elderly if they were over 65. Language matters. There's an element that is disrespectful in the presentation, in the paper, and the descriptors that are used. So it's over 65 or older Americans is very different than saying the very old or the elderly, just in terms of how you are framing that population group. It's the difference between calling people disabled or people with disabilities. Also on Jessica's point, I'm assuming you're building into this, but I couldn't quite tell. People who are at elevated risk for other reasons besides age or at increased risk. I couldn't quite tell what was going on there, but I think that's very important if you're talking about a targeted policy which is only by age or a targeted policy which is by elevated risk. The ethics are quite different. In terms of justifying a public policy that is either voluntary or enforced, directed at people who are at higher risk or who are at higher risk only because they are at an elevated age or at an older age group, there's 2 ways you can go. You can say, look, the older people have no complaint because they are the primary beneficiaries of the burdens that are being imposed on them. I actually think that's a very problematic way to go here, which has to do with the fact that I'm not sure that many people would agree that the benefits outweigh the burdens from the standpoint of older populations, depending on how strict you understand this lockdown to be. But you do have a more defensible path, which is one of reciprocity and cross-generational obligation, where you can go, I think, to make a stronger case for additional responsibility on the part of older Americans with respect to the shared obligation to reduce the burden of the pandemic broadly understood. This is going to echo, I think, something Jessica said. We've had a long tradition of failed targeted policies in public health. One of the reasons why the efficiency would say, yes, if you target, you can get more value for your investment. But when you target, you introduce all kinds of reactions, not the least of which are ethical objections. And I would just harken back to the early days of HIV testing before we had an intervention. And there was a lot of discussion about targeting HIV testing. It's going to be much more efficient if we only target it to low-income people of color and to gay men, because that's where it will sit. That produced a set of consequences and a backlash and debate in public policy that we could discuss for a long, long time. So my next 2 points are questions, really. I'm kind of hopeful about your answers, and I think right now we could use some hope. My first question has to do with your language of the lockdown is not complete, the lockdown is not perfect, and then you talk about perfect lockdown for the elderly. And I get quite confused about what it is exactly that you are assuming. I tried to figure it out, but I couldn't quite tell. I did look at your Time magazine piece, which was very helpful to me because I was trying to understand where your thinking was with respect to policy more broadly. So we do have the recognition that 10% of the elderly live in multi-generational households, as Jessica was referencing. We have sizable numbers of children in the United States, about 10%, school-age children who live with grandparents. Sometimes the grandparents are their sole caretaker. I can't imagine a public policy of any defensible public policy that would ask multi-generational families to take the elderly, the older person, out of the home. I can't imagine any situation where you would take a child and put it into foster care rather than have it cared for by an elderly grandparent. And therefore, I'm trying to figure out where on the frontier, right, your frontier of the targeted policy is something that's really realistic, not in terms of attaching economic value to life, but rather what's a realistic set of restrictions, voluntary or imposed, on older Americans that would be ethically acceptable and, as a policy matter, even feasible. So that's what I'm interested in. I'm not interested in a theoretical 100% lockdown of the elderly. That's never going to happen, nor should it happen. I am interested in knowing, where does it start to lose value? Like how much can we acknowledge the extent to which interaction across generations is inescapable, right? Right. So where is that point where we still see a big value from a policy that's targeted at people who are older Americans? Finally, my last point, and I actually had this in there, earlier, but I now feel like I want to underscore it all the more given what we're facing as a country. I see a lot of potential for this kind of work in helping us understand yet a different kind of targeting, which is, if we wanted to be able to, could we use your model, so I'll put it this way, or a model like it, to explore what policies would reduce economic losses more for low-income people and people of color, and decrease mortality more for low-income people and people of color. So a different and very important public policy question to ask, which is essentially the intersection of this work and concerns about structural injustice. So I'll stop there.
Thank you, Professor Faden. Of course, it's 1 p.m. and I understand, if people want to leave, of course, they're free to leave. We are not going to end the seminar, the webinar here, of course. I went to graduate school at the University of Chicago, and I always say I miss Chicago. And today we're having a nice Chicago-style seminar. I like that. So with that, I would like to invite Iván and all the authors who are here to offer their responses to the remarks that we just heard.
Thank you. I'm going to be brief so that my other co-authors can speak. Just thank the discussants greatly. We like sharp, hard comments. We can improve only that way. Just want to underscore, we are not assuming, this speaks to comments both discussants made, we're not assuming that the elderly are perfectly locked down. We know that can't happen, so we don't assume that. That's very important. We can change that parameter. We have a robustness check where we make it even worse what the lockdown is like. We still find it's better to target the lockdowns. And nursing homes are incredibly important. We dedicate some time in that Time article to discuss some of that. You know, around 1.5 million elderly out of 50 million elderly are in that situation, and they require special attention, no doubt. We haven't been doing a good job even with uniform lockdowns with them. So I'm not so sure how our policy interacts with that. We are willing to try anything. Where I find most useful, it's very useful to say the model's not good enough and tell us which way to improve it, gamma, parameters, or a better matrix. We'll use anything you tell us, even if it's hard work. We do believe it's better to make the models better, start with what we have and improve them and make them better. And I never claimed this is ready for immediate implementation. And as for the other discussions, I'm very sorry about the language. We will improve on that. However you tell us is the best use of language. And we agree that some of the lockdown can be interpreted as voluntary. Like the Surgeon General tells us what's risky, and many people comply with that. And there's a role, I think, just for that kind of example being given from the sort of guidelines. And I'm gonna say that I also am fascinated by thinking about the distributional issues. It's something that we can't describe fully here on this chart, but I would say is in the back of our minds thinking about this. Let me leave it to my co-authors if they have any other comments.
Daron, me, you?
I'm happy to, if you want to go ahead, or I can.
Yeah, so I guess also thanks a lot. I mean, it's really useful for us to have feedback outside of our economics world. I guess, actually, and I think it's very useful to have these two different perspectives that are outside of our economics world. I think what I would say is, and this kind of picks up on Iván's point about, not thinking that this is, the outcome of this paper is here is the policy you should follow, is that, thinking a little bit about what we bring to the table and what you guys bring to the table. We're not epidemiologists, and we will never, I think, unless we decide to completely change careers and then maybe not be good at it anyway, have a model that is as detailed about exactly what the interactions are and the household structure and everything else as the epidemiological literature. And we're also not the best people to go and implement policies, to stand up a public health policy and know exactly what is feasible and what is not. And I think, our Time magazine piece, half of the piece was talking about those ideas, but, we aren't the ones to know really how to do that. And so, I think our view a little bit is, if the paper, what does it mean for our paper to be successful? Like our paper, I think what it means for our paper to be successful would be, epidemiology, people who work with more detailed epidemiological models would take the ideas that we have and apply them in a richer model that they've spent years and years developing knowledge about. And people who are really knowledgeable about public health would take some of these ideas and ask themselves, well, what's feasible from this idea, that can be implemented? How would we do it? And what isn't? And so, at least for me, that's how I kind of think about this. I mean, if we had, Jessica, if we tried at the beginning to have, someone from the epidemiological world, the ideal for us would have been to piggyback on someone's model. In mid-March, perfectly understandably, all of those people were incredibly busy with their projects that they were trying to do to move knowledge forward on COVID. So, we decided that the way for us to have kind of explore these ideas and see what bringing an economic perspective would be to take kind of a basic core model and see how those ideas play out in it. And at least for me, and Daron and Iván and Victor can chime in and say what they think about this. That's a little bit how I view what we're doing.
Can I say something? So I'm not really addicted to very complicated models. I'm rather sympathetic to the view that when you build a really complicated model, you end up with two things you don't understand, the world and the model. I do think that there are rich, useful models in that space. I think there's many directions we can go. I don't need that particularly. I need you to tell me something I don't know, right? And that's why we build models. We do it to check the logic, and this has been a very useful exercise in checking the logic, but we also, there needs to be some step. And the point that Iván made about the compelling fact that if you do a partial lockdown, you have as much gains as the further one. Yes, and that's great. And I'm glad we have that logic. There is a way in which I feel like that's a very short paper because that is effectively, the outcome of spillovers. I'm sorry.
Yeah, so if I may just expand on that. So, I think the result that's consistently robust, and we do a little bit of that, through about 20 different robustness checks, and then we've done, 30, 40 more, is that what we call semi-targeted lockdowns have quantitatively very large effects. And I don't think that was known. And you can pick parameter values that are crazy for which that's not true. And that much more detailed targeted policies, which would be much more intrusive and perhaps ethically more problematic than, what we call protective custody for the older group. Those don't have any appreciable benefits. And we can talk about, I think there is no absolute ethical certainty and nobody has any monopoly on deciding what's ethical. But, we discussed this a little bit in the paper. The old are not locked down in our model because they create external effects on other groups. They create external effects on them, on their own group. So in other words, if you take the old from the circulating pool, which is the social pool and the work pool, that doesn't actually benefit the young and the middle-aged groups all that much, but it benefits other members of the old group. So that's the aspect that we're trying to emphasize. And then one final comment, Jessica, about one of your questions, you mentioned other comorbidities. I think that's very important, but we are not targeting other comorbidities because that's harder to do. But notice that the mortality rates by age group also include the other comorbidities. So when there is mortality among the less than 50-year-olds, for example, that's partly because of those other comorbidities, and they are already being affected by the uniform lockdown policies as we are implementing them right now. So there's no deterioration in that respect. But one could try to do that, but it would be even more intrusive. And that's why we didn't go down that direction. And there also, data-wise, it would be harder. Thank you.
Daron, can I say one thing? When I called up my mentor and suggested I put him under protective custody, I then got under the furniture because it was clear he was about to firebomb the house. I think language matters, and protective custody is maybe not the right word.
I was about to say that, and also because now I am confused. Protective custody is a terrible term, right up in there with the very old. Elderly is benign by comparison. But more than that, is it protective custody, or is it if the lockdown isn't perfect and you are, I'm very confused about the language and the paper and the implications for older people of what the frontier.
So the frontier, yes, that's right. I mean, there is some confusion there.
Yeah.
Frontier doesn't pick a point by the degree of the imperfection of the lockdown. The imperfection of the lockdown is a technological parameter. The fact that because there are multi-generation households, because even the over 65 will have to go out to do grocery shopping, or people will have to bring groceries in there, or because there are nursing homes. So we assume a parameter which says that if you perfectly lock down everybody, it's as if 1 out of 4 weren't locked down and were fully circulating. So it's actually quite liberal in that sense. It's very, very far from a perfect lockdown as you understood it. That's true for every point along the frontier. What distinguishes different points in the frontier is how much you're trading off economic costs versus lives lost.
All right, so if I understand, and my last, just so I clarify.
Sure, of course.
So the most locked down version of the lockdown, the assumption is that 1 out of 4 older Americans is in fact in contact with younger Americans.
That's right, and it's even worse than that if you do uniform, because in the uniform you're also letting the essential workers who are over 65 go to work.
Yeah.
So it's the semi-targeted or fully targeted would be that it's as if you're locking only 3 out of 4 over 65.
And so what I would, and I'm sure we all have to go, but this is a very important to me point that I'm trying to clarify for myself, and maybe I should take this offline. Is it possible to interrogate along the frontier and say, no, I don't want merely to have 1 in 4 elderly not locked down. I want the other 3/4 of the older American group to have 1 contact a week or 2
yes,
contacts
we could
a month.
do that, but that wouldn't be along the frontier. That would be changing how you organize other aspects, which is part of the parameters. So you would change the parameters and the whole frontier would shift if you
I think the value added to the policy debate with playing that kind of parameter game could be very significant.
Sure, of course. We could.
Closer to something like the real world.
Yeah.
Thank you.
Thanks. Jessica, if I could just ask a question, which would, if you, it's not a question so much, more of a request. If you could point us towards the papers that, you know, the epidemiologists have written that have, you know, you feel tell you the same things that our paper, you know, that you know, tells you, we'd really appreciate it, because we don't, I mean, we've tried to look, and, you know, I haven't personally seen papers that have done what we've done, but you may well have, and it would be really helpful if you could point us towards those.
I think that statement was unfair. Like many epidemiologists in June of 2020, I'm a bit grumpy. But I certainly think that there are many interesting papers that you might enjoy that along these threads. I do think this is a very useful, the main punchline that there are big differences is certainly useful. Yes, so I will, with pleasure, send you a bunch of comments on the paper and some references that I think might be useful.
Okay, thank you very much.
Thanks, everybody.
So I want to be respectful.
Thank you for the comments and the opportunity.
So the webinar, it is hard to cross disciplinary lines, but but it's potentially useful and fruitful, and I'm very glad that we did this, and I think this was a great webinar. Thank you again to our presenters and discussants for a really engaging conversation. Thanks to our participants for listening and asking questions and contributing to the conversation. In past webinars, we created platforms to facilitate the continuation of the conversation post-seminar, so we plan to do that after this seminar as well. We will have more webinars. Thank you again, and stay tuned for more.
Thanks a lot for doing it.
Thank you.